start. Good afternoon, everyone. Thank you for joining us today for the quarterly meeting of our Interagency Heroin and Opioid Coordinating Council. I'm speaking to you from our offices here at Schaefer Tower in Baltimore. And here with me is Steve Hsu, our Executive Director of the Opioid Operational Command Center. And it's interesting that the last time we officially met was in January 13th, as a matter of fact, at the State House in Annapolis. And while that was some time ago, it seems like years ago. And of course, a lot has changed since then, and no one would have predicted that, we would have had this unprecedented, or at least once in 100 years, pandemic that has taken over not just Maryland, the country, but also the world. So it's been a challenging time for all of us, and I just want to say on behalf of Governor Hogan, our entire administration, I want to thank all of you for the work that you've been doing as we work to address the pandemic, keep our citizens safe, and continue to move the state forward. Now, after all, given the current coronavirus pandemic, the fact that it's dominated the headlines, it doesn't mean that opioid addiction or the epidemic in this country has subsided. And as we speak about that, part of what I'd like our focus to be today and as we go forward is the effects of the coronavirus pandemic on the opioid epidemic and how it's affecting us here in Maryland as well as in the country, and how we may need to adapt to tailor our responses to this current reality. One of the major ways, of course, that we've been addressing this challenge through the pandemic is through the delivery of services, and particularly with telemedicine. Earlier during our state of emergency and the response to the pandemic, we lifted regulations allowing for more people to participate in telehealth with their providers so that they could speak directly with doctors and treatment professionals to get that type of treatment they need without having to physically travel and potentially spread or run the risk of catching the virus. And from what we're hearing, the evidence is coming back. So far, it's been successful, and we've received positive responses. Now, we know in some areas, particularly as it relates to some of the mental health challenges, it can be more of a challenge, particularly if you're working with children, because it does take a little bit more to keep their attention. And sometimes by doing it via video or telephonically, it can be a little more difficult to keep that young person's attention when you're not within a physical contact with them. But one of the things we were looking at in this, as we address this particular issue, is what are the barriers to getting service to individuals that are in need. And so telehealth is one of the areas that it can work very well. And as I mentioned, with regard to the mental health side and the challenges associated with just the stay-at-home orders, the anxiety created by the pandemic, it increases some of the challenges that we have, not just with on the heroin opioid side, but also on the mental health side. And as we've talked many times before, many individuals have co-occurring conditions that can feed off of one another and lead to utilization of these either prescription medications or other opioids that cause a problem. So later on in the program, Dr. Jones, the Deputy Secretary for Behavioral Health with the Department of Health, and Dr. Ingvild Olsen, Medical Director for the Institutes of Behavioral Resources and Reach Health Services, are going to talk to us about using and expanding telehealth services to treat substance use disorders. So at this time, I'd like to turn over to, well, and actually before I turn it over to Mr. Hsu, Director Hsu, I may want to give you, if you don't mind, a quick update on where we stand with regard to the coronavirus. It's reported on the health website, health.maryland.gov or coronavirus.maryland.gov. But also, I just will briefly state that new cases that were reported today are an additional 561 new cases, positive cases of the coronavirus. Unfortunately, we had 33 individuals pass away from the COVID-19 virus. But the good news is that our hospitalizations continue to go down. They're below 1,000, the lowest level since late April, actually mid-April, standing at 955 people in our hospitals. ICUs have also decreased. They're now below 400 at 379, and that's a decrease from the day before, and the curve is sloping with regards to our hospitalizations, which does give us a lot of encouragement. And as we continue to increase our testing, we do expect that we're going to see more cases, but with that, we're increasing, of course, the contact tracing to make sure that the spread is mitigated as best as possible. So I just want to give that brief update, and now I'll turn it over to Director Hsu.
Thank you, Lieutenant Governor, for your remarks and for your ongoing leadership in both of these incredible public health challenges that we face here in Maryland. And thank all of you who are joining us today for being part of this meeting, and also for the work that you're doing day to day. Your support and collaboration are always important, but that's especially true now as we enter a new and very uncertain phase in the substance use crisis, and as we enter a new phase in our response. I'm going to attempt to bring my slides up onto the screen. Maybe on this.
I know Bobby Neal is on the line, so he and I are both old enough to remember when there would be a test pattern put up on the screen. Oh, there we go.
Thank you, Mark.
You know, technical difficulties, TV, they go to a test pattern and they just put on the screen. So, okay, we need to get one of those little test patterns. I'd love to see it.
No, it's very tricky.
Yeah.
It seems that the term unprecedented is now more popular and probably more appropriate than ever. 2020 has presented our state with an unprecedented and increasingly complex set of public health challenges. In the process of upending nearly every aspect of our lives, the coronavirus pandemic has challenged our ability to monitor public health and to provide all manner of healthcare services. And in the process, the pandemic has complicated our ability to respond to the sustained opioid and substance use crisis, which I must remind you remains one of the greatest public health challenges ever to face our state. In just a moment, I'm going to speak to the first quarter 2020 fatalities numbers and other statistics that we use to gauge the state of the crisis. These numbers have given us great concern about the potential for an acceleration of the crisis as we emerge from the coronavirus pandemic. This means that now is the time to redouble our focus on solutions, both established and new, This also means that everybody involved in addressing the opioid crisis, every clinician, every advocacy group, every concerned parent, every citizen, and everyone attending this meeting today needs to renew their dedication to addressing this problem. The OCC released its report for the first quarter of 2020 today. During the first quarter of this year, intoxication-related deaths from all types of drugs and alcohol in Maryland, I'm sorry to say, increased when compared to the first quarter of 2019. If you look at the left-hand side of the slide, those first two bars represent all substance use-related fatalities. There were 621 fatalities in 2019, and sadly, there were 626 in the first quarter of 2019. Opioid-related deaths increased 2.6% during this period. If you look at the far right-hand side of the chart, you'll see that there were 547 opioid-related fatalities in the first quarter of 2019, but 561 in the first quarter of 2020, again, a 2.6% increase. This is a disappointing, although slight, reversal from where we stood at the end of last year when we reported opioid-related fatalities had decreased by 2.5% from 2018 levels. It is noteworthy that the decline in 2019 was the first annual decrease in opioid-related fatalities since the onset of the opioid crisis over a year ago. The synthetic opioid fentanyl was involved in the vast majority of opioid-related fatalities in the first quarter of 2020. This has been true for a long time. There were 523 fentanyl-related deaths in the first quarter of 2020, which represented 93.2% of all opioid-related deaths in Maryland. Fentanyl-related deaths increased by 4.4% from this time last year, a slight acceleration compared to the 1.5% annual increase in 2019. In keeping with a trend that goes back several quarters, fatalities related to other types of opioids decreased during the first quarter of 2020. If you look at the right-hand side of the chart, you'll see there were 97 prescription-related opioid fatalities in 2019 and 95 in 2020, a small but welcome decline. There were 142 heroin-related deaths, a decline of 28.6% from the first quarter of 2019. You can see that in the middle of this chart. And there were 95, as I said, 95 prescription opioid-related deaths, a decrease of 2.1%. We're glad to see the continuing decline in heroin-related fatalities here in Maryland. However, we also saw some very concerning increases in cocaine, alcohol, benzodiazepine, and methamphetamine-related deaths during the first quarter of 2020. These are all non-opioid intoxicants. There were 230 cocaine-related intoxication deaths in 2020, a 15% increase from this time last year. Cocaine accounted for the most non-opioid-related fatalities in the state. It was the substance most commonly mixed with opioids during the first quarter. There were 136 alcohol-related intoxication deaths in this time frame, an alarming 26% increase from the first quarter of 2019. And there were 31 benzodiazepine-related intoxication deaths and 20 methamphetamine-related intoxication deaths during the quarter, representing an even more alarming 72 and 54% rate of increase, respectively. These increases are clear indicators of a substance use crisis that has been worsened by societal upheaval. Beyond these increases in fatality rates, other troubling signs have appeared, some of them rather perplexing. Opioid-related emergency department visits and EMS naloxone administrations were down substantially in the first quarter of 2020. There were 1,261 reported opioid-related emergency department visits during this period. This was a 23.3% decrease for the first quarter of 2019, when there were 1,643 opioid-related emergency department visits for non-fatal opioid overdoses. Similarly, the number of naloxone administrations by EMS personnel decreased during the first calendar quarter of 2020. I said when I started this section, this was perplexing. In the first 15 weeks of 2020, there were 2,489 reported administrations, a decrease of 19.3% from the same time frame in 2019, when there were 3,086 administrations. Since the stay-at-home order took effect at the end of March, reported naloxone administrations have been off by about 24%. Typically, these statistics would rise in correlation with fatalities. And these declines indicate disruptions in our broader response systems that may have lingering effects on people who use drugs. It's important to consider that these metrics provide a more holistic picture of the current status of the opioid crisis in Maryland, which is a multifaceted issue with varying regional and statewide characteristics. And as I and others have mentioned, it is still impossible to understand precisely when the pandemic first affected the substance use landscape and exactly what the earliest ramifications may have been. The new challenges presented by the coronavirus pandemic need to be met head-on, so the OOCC has worked closely with partners across the substance use field to develop Maryland's COVID-19 Interagency Overdose Action Plan, which we just released this morning. We've developed this action plan in direct response to the concerning data that has emerged through our first quarter 2020 reporting process. The action plan highlights steps that we can take immediately to ensure that systems and resources are in place for individuals in need of substance use services throughout all stages of the emergency response. Some strategies and tactics are new, and some have been identified previously as priorities for the OOCC. In developing the action plan, we recognize that COVID-19 mortality rates are highest among Maryland's minority communities, and we will work to identify additional ways that we could address any racial disparities in substance use disorder service provisions or related health outcomes. As we do this, our partnerships with state and community-based organizations will be a critical component of a successful strategy implementation. In addition to rolling out the action plan, the OOCC will spend much of the next few months focusing on bringing together our stakeholders to facilitate collaboration, which is a fundamental function of our office. This summer will be filled with opioid intervention team visits, or OIT, meetings. Some of them will be held in person, but most of them will be held virtually in every county across the state. These meetings are one of our primary means of staying abreast of local efforts and identifying areas of need and our opportunities to share best practices and guidance from other jurisdictions. Additionally, our soon-to-be completed gaps analysis will help to identify components of the state's treatment network that need additional resources and to direct resources to fill those needs. In preparing the gaps analysis, we have surveyed the treatment capacity in every county and have compared that installed base to a population and mortality rate adjusted statewide standard in order to identify treatment gaps and areas that need attention. Very excited about this project. This is something we've never done before in our state. We're excited about the potential for this exercise to enhance our treatment infrastructure across the state. The OOCC looks forward to working with partners across the state to continue identifying how our systems have been disrupted in recent months and in refining our responses. Thank you for your continued support in this battle as we all work together to lay the groundwork for the months and years ahead. The OOCC will be here to help during this challenging period, and we will focus on solutions together. Thank you. Thank you, Lieutenant Governor.
Thank you, Steve. Very good presentation. Now we'll turn to Dr. Jones for her presentation.
Good morning.
Or
But
afternoon?
no, it's the afternoon. Good
Don't worry, it's
afternoon.
morning somewhere.
It's good to be with you all on today. Thank you for this opportunity to present the work that's happening with the Behavioral Health Administration. Am I presenting my own screen? Is that what I'm supposed to do? Or is someone going to present that on your side?
I think,
She presents on her.
I think you're presenting.
Okay. Let me. Okay. Let me. Okay, you can let me know when you see that.
Oh, it's up.
Okay, fantastic. So again, thank you for this time. For those of you who don't know me, my name is Dr. Alia Jones. I'm the Deputy Secretary for the Behavioral Health Administration, which is a part of the Maryland Department of Health. And happy to be with you to talk with you about how the BHA has responded to the COVID-19 crisis as it pertains to the opioid epidemic. So obviously the largest response has been around the way that services have been delivered, and this has been referenced to the timeline being the expansion of the definition of telehealth. One thing that was really important about the relaxation of regulations was the ability of using the telephone for the delivery of healthcare and services, including treatment of opioid use disorders. We appreciated the support from Secretary Neal for that expansion, as well as the governor. So that's probably one of the largest things that we did. Fortunately, on the federal level, HIPAA relaxed the platforms that were able to be used, which meant that it made telehealth more accessible to providers who were not previously using telehealth to deliver services. And then on April 30th, CMS did the same thing with expansion for telehealth services for patients who have Medicare or persons who have Medicare. Of course, services could only be delivered if they fell within the provider's scope of practice. And the nice thing was that the delivery of services using telehealth was just from a formality perspective as easy as delivering services in a live format. There were no additional authorizations that had to be garnered and no major accommodations beyond having the technology and communicating and getting consent from patients that they were going to be using a telehealth format for the receipt of services. As a result of the expansion of the telehealth services, and just to speak to the adoption of this as a way of delivering care, 85% of providers are operating via telehealth when last we counted several weeks ago. And that appears to be going very well, and we're very proud about that. One of the focuses of the Behavioral Health Administration when this COVID epidemic first began to unfurl was to ensure continuity of care for persons who were previously engaged in any kind of behavioral health care service, of course, including those who were in treatment for substance use disorders. And that would not have been possible without the extensions and the relaxations of the rules around telehealth. So some of the services that we have moved over to telehealth, so most of the services that are offered in an opioid treatment environment are able to be provided via telehealth with one major exception. Patients or clients are able to have individual assessments by counselors in this format. They're able to have groups, provided the groups are using a virtual platform where you actually can see one another. However, we did relax that regulation in residential drug treatment programs where you don't have to see the client in order to deliver the service or bill for the service. You can use a phone in that particular instance because there was control over who was going to be on the other end of the line. New patients were able and are able to be seen using telehealth for buprenorphine. So you can have a virtual visit to start on a medication like buprenorphine, which is medication-assisted treatment for opioid use disorder. However, that's not that was permitted by SAMHSA and the DEA. However, they did not relax the regulation around the initiation of methadone to a virtual format. So if a patient is on methadone, they have to come into a clinic environment in order to have their initial assessment by the nurse. However, the physician can do a virtual evaluation if they choose to do that, so as not to hinder the initiation of the medication. And I know that Dr. Olson will speak more about that. Intensive outpatient programs are able to be delivered using telehealth. We actually relaxed the duration of hours of service that had to be delivered, so that we were able to allow people to have some access to IOP level services. However, with just several hours reduced, so that the service could continue to be provided. And telehealth is being used in residential settings for lots of the interactions there. And that has been very helpful to decrease movement in residential environments and has kept infected staff members from coming into, and people who didn't know that they were sick, from coming into these environments for care. I will note that we've never told treatment providers that they should not have patients come in unless they have a negative test for COVID, because that's not consistent with what we understand about COVID-19, meaning that the test could be negative today, but that doesn't necessarily mean that a person is not positive for COVID-19. However, we did provide lots of information and guidance around how to provide services in a safe way. We worked with the Maryland Board of Professional Counselors with the support of Secretary Neal to get facilitate the allowance of trainees to provide services in a telehealth format, because they're not licensed providers. That was they were initially excluded from the ability to provide services. However, these providers, these clinicians provide a lot of support and deliver a lot of care and support in drug treatment programs, whether they're methadone maintenance programs, other medication-assisted treatment programs, or residential drug treatment programs. They constitute a large part of the workforce depending upon the jurisdiction. And so we were grateful that the Maryland Board of Professional Counselors made that accommodation. Based upon the information that it is that we've received, so we recently did a provider survey that closed this past Friday, so it's still actively being analyzed. However, we put it into the provider space, and we had over 800 providers respond and talking. We were looking for information about the impact of telehealth on patients' health-seeking behaviors. And the feedback that we've gotten has been overwhelmingly positive in that the expansion to telehealth has increased access to treatment, has eliminated transportation challenges, and has increased engagement to treatment for some people who had been hard to engage prior to the ability to use telehealth for care. In order to improve, so the first part of our response to the COVID pandemic was to ensure continuity of care. Our second or next phase of response from the Behavioral Health Administration was to ensure that people who had new substance use disorders or who were looking to get into treatment knew how to access those services. And so that's something that we have been heavily focusing on for the past several months at this point. One of the things that we did was developed a telehealth resource guide and an interactive telehealth map, which is located on our website, which allows people to look at their own jurisdictions and identify providers, behavioral health providers in their communities who are accepting patients via telehealth. One of the things I didn't mention on that slide is we have provided information for patients around how to access resources for support groups in a virtual environment, as most of the support groups closed, particularly initially in response to COVID-19, when there were only when there was only essential movement at that time. We recently learned that telehealth services are slated to potentially end on July 25th when when the health emergency declaration is removed on a federal level. We're working closely with our partners at Maryland Medicaid to look at how this will impact the service delivery system and what changes that will mean for providers. Of course, at this time, we don't have any reason to support a rollback of the allowances that have been extended to date. However, we certainly support increased flexibility and continued flexibility for patients to be able to access services in a way that's safest for them. So we're continuing to look at the information from the survey that we collected, hear back from our providers. However, the overwhelming feedback has been that this has been a true benefit for the behavioral health community, including those who have substance use disorders, and we should continue to support this. Policies and regulations that have been relaxed or waived. I know that Dr. Olson will talk about this as well, in that there was a relaxation of the ability or relaxation around the regulations about how much medication a patient could be released, could be released if needed. And so Maryland supported DEA and SAMHSA's waiver, blanket waiver, which allowed patients to receive anywhere from 14 to 28 days worth of take-home medication, depending upon where they were in their recovery journey. The feedback that I have received has been that that has gone very well. And there have been very few. It's not practiced across the board. Obviously, it's only for patients for whom the medical directors feel that it's appropriate. However, it's gone very well. We have extended certificate of compliance for certified recovery residences, so ensuring that licenses were not interrupted to ensure that there was, again, no interruption in services during this time. And some of the challenges. So the biggest challenge has really just been helping people know how to operate in this space. The Behavioral Health Administration, our role has largely been, in addition to the things mentioned, but also to provide as much information to the behavioral health community, including our substance use provider community, around how to ensure that patients were receiving care in a safe way. We provided lots of guidance initially around how to work within the CDC recommendations for infection control, whether that was in an outpatient or an inpatient environment. And we have advocated ferociously for PPE for our providers in various treatment settings, as behavioral health providers in some jurisdictions are low on the totem pole to receive PPE and not on the totem pole at all in others. So that's been a constant struggle. However, we have been very appreciative of the support that we've gotten from the Maryland Department of Health overall, from operations and management and managing of the PPE. They have also been very strong advocates of ours to help ensure that our providers have the PPE that they need. However, I will say that there continues to be a need, particularly as people are moving around more and as more patients are coming in for services as the state continues to go through its roadmap to recovery. And I will end with that and turn this over to Dr. Olson. Thank you.
Jones? Dr. Olson?
Can you hear me?
Yes.
Yep, great, wonderful. Well, thank you so much, and thank you so much for having me. I'm going to now try and pull up my slides. And let me, give me 1 second here. I want to just share these. Let's see. Okay. Okay. All right, are you all able to see my slides there?
Yes. Yes, we can.
Okay, great. Wonderful. So, so thank you again for having me as part of this, and and thank you also to. I want to echo my thanks that from Dr. Jones. Thank you to Dr. Jones as well as Secretary Neal and the governor and all of you, really for just the tremendous support of behavioral health providers and in particular. Opioid treatment programs, as well as other addiction treatment specialists during this just unbelievably unprecedented, as Director Hsu mentioned, and uncertain time. I think we have all learned a lot of lessons, and we are going to continue to learn some lessons out of this pandemic, and certainly Lieutenant Governor, as you mentioned, that the opioid epidemic and the opioid crisis and what we're seeing now from the data, really kind of an addiction crisis, is unfortunately also going to be part of that. So just a very quick word about IBR Reach for those of you who may not be familiar with our program. I am the medical director. We are a comprehensive outpatient specialty addiction treatment center in Baltimore City. We serve primarily residents from Baltimore City, but we also do have some patients who move around some into Baltimore County, Anne Arundel County, Howard County, but that is the minority. We provide a host of services, including medications for addiction treatment, such as methadone, buprenorphine, naltrexone. We treat alcohol use disorder and all the other substance use disorders, many of which really there is no pharmacological therapy for. So it really is dependent on then individual and group counseling services. We also have an intensive outpatient program, several peer support specialists who provide a tremendous amount of service to our patients. Health home service, we provide hepatitis C treatment, and we have a special focus on outreach and support services for the LGBTQ population and African American women through a SAMHSA grant. Our annual patient population is around 700, and I'm going to tell you a little bit more about kind of how this, not only the COVID situation, but also then specifically telehealth services have been able to meet the needs of our population given some of their demographics. So, as Dr. Jones mentioned, that when the start of COVID happened, in early March, I think for us, that the regulations changed very quickly, thankfully. And I am so grateful for SAMHSA, the DEA, CMS, and then all of the state level policy changes that really allowed us to pivot extremely quickly to then be able to dramatically change how we were operating and how we were providing services, given the risk of COVID, given the uncertainty, but really be able to continue to provide the levels of services, or at least continue to provide services in the way that we wanted to make sure that we were connecting patients, keeping them safe, but also not disrupting their care, and still be able to take new patients and remain open for business. The flexibility for the take-home medication for opioid treatment programs that Dr. Jones mentioned. It really has been just a godsend. I mean, we moved to try and cut our daily volume of patients accessing care in person by about 50%. And we were able to do that through the flexibility that we had for take-home medication. We have patients who are getting a week of methadone at a time, 2 weeks, 3 weeks, and 4 weeks. And then we have a handful of patients who still really need to come in 3 times a week, 4 times a week, 5 times a week, but it's a handful. And it has allowed us really to be able to effectively screen people at our entrance for potential COVID type symptoms, for potential exposure, and also then be able to maintain the physical distancing that is recommended within our facility. We did have to put on hold some of our services, our intensive outpatient program, for example, because we just do not have the physical space to really provide that physical distancing that is required. But because of the availability of telehealth and all of the both federal and then state level policy changes that allowed for that, we have really been able to continue to connect to patients and do that in a way that has really been able to keep our patients connected, keep them safe, and keep our staff safe. I think there was a tremendous amount of anxiety and stress, not only among the people who were accessing our services, but also among our staff. We have had one of our part-time physicians, in fact, develop COVID. We've had another staff member who was out isolating with COVID. We have had several staff members whose close relatives and family members have passed away because of COVID. And so certainly this is something that, we have all felt, not just, kind of among our patients, but also then just as staff. And the ability then to use and not have to worry about kind of the HIPAA compliance and use platforms that ordinarily we do not have access to. Most opioid treatment programs, most behavioral health practices in general, and particularly addiction treatment facilities, this is not something that they have really had in their armamentarium because of insurance-related reimbursement issues, as well as some of the state regulations that has just not made that possible. And so the equipment that we didn't have any equipment that really enabled us to do this. When the secretary allowed for the trainee status to really be able to actually participate in telehealth services, as Dr. Jones mentioned, that was something that was incredibly important because it also meant that we could then have our complement of healthcare professionals and staff really be able to provide all of the not only the audiovisual, but then the phone-only services. That we have heard has been particularly important for many of the rural addiction treatment centers and facilities, because their trainees make up a large percentage of their workforce and their staff. And without really being able to have them be able to use that telehealth flexibility, that really would have significantly impacted the ability for them to provide services, particularly because in those areas, transportation has been such a big issue. So I just wanted to take a few more minutes and just kind of go through some of the lessons that we've learned, particularly with the focus on telehealth, as I said, to date, because we're still learning more and more as this all evolves. I think one of the things that I worried about significantly at the beginning of this was two things. One was, how are we going to be able to continue to provide the life-saving medication that many of our patients depend on? while keeping them safe from COVID, keeping them, safe from overdose, keeping them, safe from all the other health conditions that they live with, and really being able to then stay connected to them, because that was one of the ways that we thought we can provide people with larger amounts of medication, but we really need to be able to actually take the time to connect to them. That has been incredibly important for our patients. I can't tell you how many times I've been on the phone with a patient who says, I am so grateful that we can do this. I am so grateful that, you are calling me, checking in on me. And our staff have really, taken the time, because for some of them, it has taken some time to adapt to this new way of providing service. Not everyone is comfortable with the phone, but we have really been able to use it as that very valuable addition to the in-person visits that we're also continuing to a much, much, much lower extent. As I mentioned, the involvement of our counselors with trainee status has been critical. That really is something that has allowed all of our staff to be able to participate. And the phone-only flexibility has been, so necessary. 50% of our patients only have access to a phone. They do not have the data plans, the types of phones, or the types of equipment at home to be able to actually use the visual component. And this was one thing that we worried a lot about, particularly at the beginning, because I knew that there were people that we were just not going to be able to reach if they were required to use the audiovisual platform. And we have had some patients, some of our older folks, who they may have some capability to use some audiovisual pieces. They've had their families help them and so forth, but it has been really I think a learning opportunity for everyone. With the audiovisual, what has been really nice about that is that we have actually been able to get a view into the home environments of patients that was not very easy to do before. We do home visits. We were doing them before COVID. We've done them now because of the availability of actually being able to deliver with some of the DEA rule changes. We can deliver medication to patients quote on the doorstep, being able to do hands-free deliveries, making sure that patients are actually then still getting the medication. But with that, we've been able to understand, what are their home environments? What do they look like? What kind of resources do they have in the home? Is housing, even though they might have a home, is it just a room that has no furniture in it? Is it an apartment that, has lots of mold on the wall and we never knew about that? So who is at home? And how are they kind of able to move around in their home? So it has really been, I think, a very interesting kind of glimpse, and has given us some great therapeutic information that we really didn't have otherwise. And we certainly have seen that patients have been extremely worried about their own COVID risk, justifiably so. 60% of our 700 patients or so are over the age of 50, and about 26% of them are, 60% are over age 50, and about 26% are over age 60. And we have a very high percentage of high-risk health conditions that put patients at risk for severe COVID illness, including diabetes and hypertension and pulmonary conditions. Smoking has been identified as a risk factor. Between 70 and 80% of our population smokes. We do a lot of smoking cessation and treatment, including medications for that. And so really being able to actually allay their fears about, yes, no, we can still keep in touch with you. We will call you. We've actually increased our contacts with patients because we are now able to, call them. For some patients who are really in this high-risk category, we're calling them every 1 to 2 weeks between myself, our other medical providers, and their counselors. So I think that as an additional tool moving forward, particularly when we are uncertain as to what will happen in the later summer, in the fall, with respect to COVID. Fortunately, we have not had any patient deaths from COVID. We have had, several patients who have been hospitalized or have been quarantined at home because of COVID-like symptoms. We are now also seeing more patients who are showing up in emergency departments because of the medical problems that they had that they were not quite as able to take care of with their primary care providers. And so we have been doing as much as we possibly can through our health home services to remain connected to patients with respect to their other health conditions. But that is certainly something that we then have been able to follow up with patients after their hospitalization by phone. We've been able to plan their return to clinic as a way of really establishing, how safe are they? How healthy are they? And so as an addition to in-person visits, because I don't think that any of us really expect that telehealth is completely necessarily going to take the place of all in-person visits for addiction treatment, but it has been an extremely valuable addition. And I would, I think, at this point, seeing that go away at the end of July, I think would be a significant loss in our ability not only to continue treating all of the substance use disorders that people are dealing with, as well as stay connected to patients and still be able to really keep people safe from the COVID virus, not only our patients, but our staff. So I think I'm going to end there, and I'm happy to take questions.
Let me just ask, when we're talking about the telehealth services ending in July, that's really related to Medicaid, but not necessarily the private side.
Yeah, I'm going to defer to Dr. Jones on that. I will say that the ability for us to get reimbursed for all the telehealth visits that we've been doing on par with our in-person visits has really been critical in keeping us, and I know many other behavioral health providers, afloat. Right. Because we had to suspend our intensive outpatient programs and all of our other group counseling visits, IBR, and I know many, other centers have really taken a financial hit. As a nonprofit, that if we hadn't been able to get the reimbursement from Medicaid, about close to 80% of our patient population is Medicaid enrolled, then we would have had to close our doors, I think, probably at least a couple of months ago.
Right.
And that's certainly what's happening in other parts of the country, is that the infrastructure for behavioral health is dismantling in a lot of parts of the country because of the volumes that have necessarily gone down to keep people safe, but there's no financial resources for the businesses to continue. Which is certainly not what you want in the middle of a pandemic that we know is going to lead to increases in need for behavioral health services and critical incidents in the behavioral health space, including overdoses.
I was asking the question because I know the legislature in Maryland passed legislation to expand telehealth. So I guess that really affects more on the private side, whereas on Medicaid, it's the federal programs. So is it the federal program that expires in July? And then the second part to that question would be, is there anything we can do? I don't know if the federal program is in regulations in the Medicaid system, or and statute that becomes much more difficult because of everything Congress to act and the President to sign it. So is it more on the Medicaid side than it is on the private because we've taken care of that in Maryland? Is that correct?
So it's, I don't think I can fully answer that question. I do believe it's a greater issue on the Medicaid side than the private insurance side, because the Medicaid side is regulated by CMS and what they'll allow and won't allow and what they'll pay for or not. In Maryland, telehealth has been expanded so that providers can deliver services from their home. However, patients cannot receive services in their home. And so when this waiver goes away, patients won't be able to stay home and receive services. So that is one of the bigger concerns. There's some other concerns as well, but the destination at home as a destination that will be reimbursed is where the challenge lies.
And when you're saying reimbursed, this is on the Medicaid side.
Correct. That's correct.
That doesn't apply to the private insurance?
I don't believe that it applies to the private insurers, because the private insurers had greater limitations than Medicaid had previously. And with all the changes that happened in this space, the private insurers, they came along actually more slowly with regards to reacting to COVID-19, so that their independence from that perspective lends me to believe that they're independent with regards to what it is that they will and will not pay for, so they can continue to pay for services wherever they allow services to be. So I think that that's more of a private versus a public issue.
Okay. Well, I guess then maybe a question for Secretary Neal, and whether there's anything that we should do in terms of the state, a letter from the governor and myself and the secretary to CMS, to our state legislature or our congressional delegation, asking that they make this permanent to be able to provide the telehealth services. And because if nothing else, it's an adjunct to, person to person. Just let's assume that we get past the corona pandemic and we get to some new form of normalcy. I think there's still a benefit in having that telehealth services and being available for patients that, for whatever reason can't leave. And like I think the presentation said, transportation can be a barrier. It's not feeling like it can be a barrier. So, this would be a way that you could still have that contact with this vulnerable population, and it's sometimes at a critical time.
I also, if I may, my understanding is that there was a telehealth bill that was put forth in this past legislative session that would have expanded telehealth services to all behavioral health services, so that, as Dr. Jones mentioned, that the patient could actually be at home and then receive the telehealth services. My understanding is that was expanded to mental health providers, but not actually to substance use treatment providers. And so that may be kind of another piece to look at.
Okay, all right.
And the other part is being able to use phone versus having to have a visual platform that you're using.
Being able to use telephone, right?
Yeah.
All right. Thank you all. Before we close, we did receive a number of public comments since we weren't able to, given that this is the first time doing this in a virtual setting, take public comment in person. We did ask if there were anyone who wanted to submit a comment to submit it to us online. And so we have Marianne Gibson is going to read the public comments testimony that came in. Oh, Mary.
Good afternoon, everyone. Thank you for allowing me to read this testimony. We received 4 pieces of testimony from our partners. The first is from the National Council on Alcoholism and Drug Dependence, the Maryland chapter. Dear Deputy Director Ricard, thank you for accepting public comment for the Interagency Heroin and Opioid Coordinating Council's meeting. NCAD Maryland, like all those in the arena of substance use and mental health services, has been working nonstop since the pandemic and state of emergency were declared in March. We have been monitoring the impact on people in need of treatment and those in recovery, and working closely with treatment providers, recovery residences, and peers to directly help individuals and weigh in on needed policy changes. There are many areas of concern at this time regarding access to treatment and recovery supports. We are grateful for the lengths to which the state and federal government has relaxed numerous rules and regulations to promote this during the stay-at-home orders. We believe many of these relaxations need to continue into the foreseeable future and some permanently. These comments below are some of the suggestions and recommendations made by stakeholders from around the state. Immediate needs. There are concerns about a disruption to the drug supply chain, leading to higher prices for drugs and increasing the manufacturing of synthetic drugs. This, coupled with growing unemployment, can create an opportunity where people with substance use disorders are more likely to turn to help. Maryland should do everything in its power to open access to treatment at this moment. This includes increasing outreach to people in their communities and connecting them to providers, promoting training for physicians, nurse practitioners, and physician assistants in order to prescribe buprenorphine, ensuring adequate funding exists for treatment providers struggling financially at this time, creating a way for treatment programs to communicate with the Behavioral Health Administration and or local authorities about whether or not they are admitting new patients during the crisis in order to make the information available to the public, and creating alternative care sites such as advanced medical tents for the provision of residential levels of care to people who test positive for COVID-19. Short-term needs. As it is well documented that traumatic events that happen at the community level lead to increases in substance use, overdoses, and suicides, the public behavioral health system must be prepared and supported for a surge in people seeking help. Steps should include the protection of the budgeted 4% reimbursement rate increase planned to take effect in less than a month, the retention of expanded allowance of the use of both telehealth and telephonic service delivery and its reimbursement, an increase in testing and PPE resources for behavioral health providers and those conducting outreach, the establishment of overdose prevention sites to reduce the incidence of death, and clear and consistent guidance on how recovery residences and treatment programs should be operating in the face of the pandemic and likely resurgence. Related services. There are a myriad of other issues facing vulnerable people, including people who interact with the public behavioral health system. While in no way limited to people with substance use and mental health disorders, there are other services that need to be in place to help people access treatment and harm reduction services and maintain recovery. With the courts in Maryland opening in the coming weeks, there is great concern about the impact that unemployment is having on the ability of people to pay their rent and mortgages. Unstable housing is a threat to a person's access to treatment and their ability to maintain recovery. The state must invest additional resources in eviction prevention funds. The state should ensure training opportunities are provided as specific areas of professional need are identified. For example, there is a need to provide training to clinicians, peer counselors, and family navigators on financial management coaching. As people receive stimulus checks and unemployment assistance, ensuring they are being provided sound advice regarding how to handle lump sums of cash is something that will help those helping others make appropriate plans. There is growing attention being paid to the level of quality of health care in prison facilities and local detention centers. This includes the availability of medications and counseling for people with substance use and mental health disorders, not to mention the ability of facilities to prevent and respond to the spread of COVID-19 or any communicable disease. A pandemic should not restrict a person's access to appropriate health care. Plans must be put into place to ensure these services can be provided at a high quality. Thank you for considering these recommendations. We hope to maintain open, productive communication with our state partners as we work together to address these two public health crises. If you have questions, please contact me at nancy@ncadmaryland.org. Signed, Nancy Rosen-Cohen, the Executive Director of NCAD Maryland. Our next piece of testimony was submitted by the Baltimore Harm Reduction Coalition. Dear Interagency Heroin and Opioid Coordinating Council, while attention has rightly shifted to mitigate the COVID-19 pandemic, we cannot lose sight of the other public health crisis we are still battling, the overdose crisis. We have lost more than 10,000 Marylanders to overdose over the last 5 years, and we can expect to see an increase during and after this pandemic if proactive measures are not taken. As we know from racial disparity data, COVID-19 infection does not discriminate, but magnifies existing inequities. People who use drugs are already marginalized and underserved by healthcare systems, largely because of criminalization and stigma, which is compounded by racism and other forms of oppression. People who use drugs often experience underlying health conditions, higher rates of poverty, unemployment, homelessness, and lack of access to vital resources, all of which creates higher risk for acquiring and having complications from viral infections. Marylanders have long lacked adequate and consistent access to naloxone, harm reduction and recovery supports, and formal treatment options. This is an increasingly dangerous state of affairs during a global emergency, as access to life-sustaining services has changed dramatically in order for programs to adhere to social distancing protocols. In order to reduce the risk of COVID-19 infection, involuntary drug withdrawal, transmission of other infectious diseases such as HIV and viral hepatitis and overdose, we urge you to take action to protect the health and human rights of people who use drugs. The first recommendation, prioritize harm reduction and decriminalize safety. Harm reduction programs must be officially declared essential life-saving public health programs and be given increased funding and resources to continue or intensify the distribution of naloxone, personal hygiene supplies, safer sex supplies, syringe services, and other safety information and provisions. Furthermore, during this time of heightened awareness of viral transmission, the state must make every effort to encourage the distribution of single-use items for drug use and discourage people from sharing any drug use equipment, including items to smoke or sniff drugs. Therefore, it is essential that the possession and distribution of all drug paraphernalia for personal use be decriminalized so that people can access and properly dispose of these items without fear of police interference. Recommendation 2, authorize the establishment of overdose prevention sites. As emergency responders and hospitals are pushed to their capacity due to COVID-19, they take longer to respond to medical emergencies. And due to stigma, there is an added danger of people who use drugs being deprioritized for care. In the event of an opioid overdose, even a couple of minutes of delay can mean the difference between life and death. Furthermore, all efforts should be made to divert avoidable interactions with emergency responders so they can focus on COVID-19 patients. Overdose prevention sites are the least costly, most effective way to reach people who are most at risk of overdose and who are marginalized from traditional healthcare structures. There are community-based organizations around the state who are eager to set up spaces for people who use drugs safely. With emergency authorization of overdose prevention sites, people who use drugs can access a myriad of life-saving services, including using drugs in the presence of trained staff equipped with naloxone and other safety tools without the worry of police interference. People who use drugs in isolation are at increased risk of fatal overdose. This is why existing overdose prevention sites around the world have already adapted their policies to account for social distancing and have continued to save lives. As we face an unprecedented global public health crisis, it is more important than ever we recognize the needs of our most vulnerable populations and work to protect the health and well-being of people who use drugs and sex workers. As the state moves forward to address this pandemic, we must implement innovative strategies to reduce death and increase access to care and support so that no one is left behind. Sincerely, Harriet Smith, Rajani Gudula-Valetti, and Tricia Christensen from the Baltimore Harm Reduction Coalition. Our third piece of testimony is from the Maryland Coalition of Families. The Maryland Coalition of Families Substance Use Family Navigation Program provides education, resources, advocacy, and emotional support to families or individuals who care for someone with a substance use disorder. Using a peer support model, MCF Family Peer Support Specialists offer support, information about resources, and assistance accessing treatment and recovery supports. As the majority of families seeking services from the program have a member or loved one with an opioid disorder, this program is an effective strategy to link those with opioid disorders to treatment and recovery supports. During the COVID-19 crisis, our substance use peer support specialists have observed a number of concerning trends. They report that overdoses have increased, as well as overdose deaths in a number of jurisdictions across the state. They attribute this to a number of factors. 1, many people are being rapidly released from jails and prisons. They are using and overdosing. 2, people who have been in recovery have lost their support system, meetings, and social connections. This, coupled with anxiety and stress owing to COVID-19, are causing relapses and overdoses. 3, virtual meetings are not adequate for some people in recovery. In addition, many lack the technology, they don't have computer or internet access to participate in virtual meetings. And 4, people are relapsing because they have greater access to cash, stimulus and unemployment checks, along with nothing to do. Our substance use staff have observed other concerning trends. They have seen an increase in people using crack cocaine, which sometimes is laced with fentanyl. They also reported that there is a larger market for buprenorphine. At the same time, it has been harder to get into treatment in some places. For a time, there were no new treatment beds on the Eastern Shore, and many treatment centers have only been taking new admissions that are bed to bed. Outpatient treatment services offered through telehealth are inaccessible to some who have no access to a computer or the internet. We appreciate the opportunity to offer these comments. Signed, Ann Geddes, the Director of Public Policy with the Maryland Coalition of Families. And our last piece is from the Maryland DC Society of Addiction Medicine. The MDD-CSAM is the Maryland state chapter of the American Society of Addiction Medicine, whose members are physicians and other healthcare providers who treat people with substance use disorders. Dear Lieutenant Governor Boyd Rutherford and members of the council, on behalf of MDD-CSAM, members in the populations we serve, we urge continuing most of the liberalized telehealth procedures for behavioral health after the COVID state of emergency is over. Services are now temporarily accessible through telehealth for many patients who otherwise would not receive them at all under pre-COVID telehealth rules. Lower barrier telehealth is not just a convenience. It actually prevents many people from falling through the cracks. Populations that need behavioral health services, on average, are less likely to own smartphones and are more likely to experience challenges in accessing transportation and keeping their regular appointments on time. The heartbreaking reality is that dropping out of treatment has become a routine occurrence because of unnecessary barriers to service. The definition of telehealth as strictly non-telephonic and inaccessible to anyone from their home undermines most of the advantages. While being cognizant of the confidentiality risks, we now know from experience that the benefits outweigh those risks in most circumstances. Signed, Joseph Adams, the chair of the MDD-CSAM Public Policy Committee.
Thank you very much, Marianne. Thank you very much. So all those comments will be put into the record. Many of the challenges that they've identified are things that we're well aware of, and particularly some of the discussions about people moving to certain drugs and the needs. And we've been talking, I guess, for the last year or more about the increase in cocaine use. It's been the last couple of years that cocaine has moved beyond heroin and often mixed with fentanyl, where we're seeing a lot of overdoses take place. So thank you, and thanks to all those who submitted those comments. As we close now and we look forward, I'd like that our continued focus be on how we can make some of the regulations that were relaxed, such as telework or telehealth, during the COVID pandemic, and how we can make those permanent, removing barriers to treatment, which I think some of the those who submitted testimony are concerned about, and of course, hearing from Drs. Jones and Olson that we're concerned about it. So we need to look at how we can do that, how we can possibly make telehealth permanent, how we can continue and expand it to make sure that it's available to those who need it and want it. As we are looking at recovery from the pandemic, we probably should look at all of our rules that we put in place and regulations that we've waived during this time to see if they can be put in place permanently, again, to decrease barriers to treatment. Understanding that telehealth may not be best for everyone, but it is another tool in our toolbox as we try to address this challenge and deliver services to individuals who are vulnerable in difficult situations. So I wanted to say thank you again to everyone who's been on this virtual call, virtual meeting. Our next meeting will be in the early fall, next quarterly meeting, and I want to thank Director Hsu for being here live, and then everyone else for being able to participate in this virtual meeting of our Interagency Heroin and Opioid Coordinating Council. So thank you again.
Thank you. Thank you for your leadership.
Thank you very much. Thank you for your leadership now and in the future, and stay safe.
Thank you to everyone, yes. Okay, that's weird. It says record. Thank you, Steve.
Thank you. It worked out?
Yeah.
Oh, gee.